Hi, this is Rami Doukky. I'm the Chief of Cardiology at John H. Stroger Hospital of Cook County and a Professor of Medicine at Rush Medical College. Today we will be presenting a case of a 58-year-old man with exertional chest discomfort as part of our Refer Wisely series. So this is a 58-year-old man presented with to his primary care physician with 3-month history of exertional retrosternal chest discomfort, which is relieved after 3 to 5 minutes of resting. His discomfort occurs when he walks at a fast pace for 2 to 3 blocks or climbs 2 flights of stairs. But he can walk approximately a mile at slow pace without problems. His past medical history includes hypertension, which is managed with lifestyle modification, and also he has type 2 diabetes for the past 5 years. He never smoked tobacco, he drinks alcohol socially, and does not use any illicit drugs. He has no significant family history. His medications include 1,000 milligrams of metformin. He takes orally twice a day. On physical examination, his blood pressure was 143/91, heart rate 58, respiration 14, he's afebrile. He's slightly obese, BMI of 33. The rest of his physical exam is unremarkable. His metabolic panel and complete blood count were unremarkable as well. His fasting lipid panel is significant for HDL of 33 and LDL of 167 milligram per deciliter. His baseline EKG shows a normal sinus rhythm, pretty much unremarkable except for small Q waves in the inferior leads that do not meet criteria for pathologic Q waves. So in summary, this is a middle-aged man with stable typical angina pectoris at moderate activity of daily living or Canadian Cardiovascular Society Class 2. So what we're going to be discussing today is what's the best next step in the management of this gentleman. So we have a few options here. One is to start long-acting nitroglycerin and reassess his situation in 3 months. Initiate hydrochlorothiazide for blood pressure control and reassess him in 3 months. Refer for exercise tolerance test, ETT, without imaging. Refer to a cardiologist for invasive coronary angiography. Refer for exercise stress radionuclide myocardial perfusion imaging, in short, MPI. So in review of this case, this is a middle-aged man with typical angina, being exertional, relieved with rest, and retrosternal. So if we look at the Diemer and Forrester for pretest probability of coronary artery disease based on age, sex, and symptoms, he would come as a high likelihood of having coronary artery disease. And this is a table taken right out of the American College of Cardiology, American Society of Nuclear Cardiology, appropriate use criteria for the assessment of stable coronary artery disease. And here, high pretest likelihood indicates greater than 90% likelihood of coronary disease. So what we're dealing with here is really not an issue of diagnosis, as the pretest likelihood is quite high. We are dealing with a different question. Number one, what is the prognosis of this gentleman? And based on this prognosis, what is the best course of action, or what's the best management? So let's go back and rediscuss our options. So one is to start long-acting nitroglycerin and reassess in 3 months, or initiate hydrochlorothiazide and reassess in 3 months. Although controlling blood pressure and controlling angina is certainly is a good idea. However, this gentleman being diabetic with what it appears to be high likelihood of coronary disease, he may benefit from additional medical therapies such as high-dose statin, ACE inhibitors, beta blockers. Also, we need to better define his prognosis in order to decide whether medical management is best course of action versus coronary revascularization. Therefore, simple medical therapy with nitrate and hydrochlorothiazide may not be sufficient. So what about the other options? Exercise treadmill test, or so-called exercise tolerance test, ETT, without imaging, coronary angiography, or exercise myocardial perfusion imaging, in short, MPI. These are all reasonable options and provide additional risk stratification. In fact, if we look at the appropriate use criteria for the assessment of stable ischemic heart disease, we will find this gentleman would be a high pretest likelihood of coronary artery disease. He's got EKG that's interpretable for myocardial ischemia, and he's able to exercise. So if we look at this table, we'll see that exercise EKG or exercise treadmill test, ETT, is a maybe appropriate for the assessment, whereas stress myocardial perfusion imaging, and here indicated as stress RNI, radionuclear angiography, is appropriate. Stress echocardiography is also appropriate. Stress cardiac magnetic resonance imaging, or CMR, is also appropriate. Calcium scoring is rarely appropriate, indicated by R, and since the patient is already symptomatic, and calcium score is beneficial only in patients who are asymptomatic to further define their long-term risk. Coronary cardiac computed tomography is maybe appropriate, and the reason it's not perfectly appropriate in this situation because the patient can exercise and has interpretable EKG, and we would miss on a lot of the physiologic data with the cardiac CT. Invasive coronary angiography would be appropriate given that he has typical stable angina and has high pretest likelihood of coronary artery disease. So any of the options of coronary angiography, stress myocardial perfusion imaging, stress echo, stress cardiac magnetic resonance imaging are appropriate, whereas stress EKG is maybe appropriate. So how do we decide? So in this case, exercise treadmill tests provide incremental prognostic information to clinical data alone, and that's why we perform exercise treadmill tests in the assessment of chest pain for many patients. However, myocardial perfusion imaging add incremental prognostic data. Similarly, coronary angiography, or CAS in this illustration, also provides incremental prognostic information beyond exercise treadmill test. However, stress myocardial perfusion imaging provides incremental prognostic data above and beyond coronary angiography. On the other hand, coronary angiography does not provide incremental prognostic value beyond stress myocardial perfusion imaging. Therefore, based on the scenario presented to us, stress myocardial perfusion imaging seems like a reasonable course of action to better define his risk, and as we are going to learn later, how we're going to guide his management. Many practitioners might argue that going straight to coronary angiography would be a reasonable course of action as well, and that will be perfectly fine as well. Again, this is a high pretest likelihood of coronary disease. Going directly to coronary angiography would be appropriate, and that is why the appropriate use criteria indicated that coronary angiography is appropriate in this case. And that's where physician practice, experience, and judgment would come into place of where how to better assess this patient going forward. So, as we stated before, stress echo, stress MRI, and stress myocardial perfusion imaging would be appropriate in this case, as would be stress myocardial perfusion imaging. The patient, in fact, did undergo stress myocardial perfusion imaging. And before we get into the imaging part, on the EKG during a peak exercise, he has an upsloping ST segment depression, most apparent in the lateral leads. He exercised for 6.5 minutes, and his exercise was limited by dyspnea, but he had no chest discomfort. In the recovery phase, however, he developed 0.5 millimeter downsloping ST segment depression, most apparent in the lateral lead in V5 and V6, to lesser extent in lead 2 and lead 3. So how we're going to use this exercise treadmill data to better define risk? So we commonly use so-called the Doukky treadmill score, in short DTS, which is a very simple score to calculate: exercise time in minutes minus 5 multiplied by the magnitude of ST segment depression, minus 4 multiplied by the angina index. And the angina index 0 for no angina, 1 for non-limiting angina, and 2 for exercise-limiting angina during the treadmill test. So the Douk treadmill score, when it's greater than 5, it's low risk. When it's less than 5, up to -10 is moderate risk. And when it's less than -10, it's considered high risk. In this situation, we have exercise time was 6.5 minutes. He had a 0.5 millimeter ST segment depression multiplied by 5, -4 multiplied by the angina index. In this case, he did not have angina during treadmill test. Therefore, his Douk treadmill score is 4.5. Therefore, he would be at moderate risk. There are plenty of online calculators that can not only calculate the Douk treadmill score, but also can provide you with risk information for the particular patient. This is a more expanded table of risk based on the Douk treadmill score. And as you would see, the top part of the table is for men. And as the patients progress from low, moderate to high Douk treadmill risk, mortality would increase from 0.9 to 2.9 to 8.3. And for women, you'll see the same thing, except women have slightly lower risk than men. On the other hand, also as a Douk treadmill score increased from low to moderate to high, the likelihood of multi-vessel disease and left main disease also goes up to the right side of the table from 11.4, 38.7 to 71.5% for men, and similarly goes up in a stepwise fashion for women as well. So for this gentleman, he has moderate Douk treadmill score. His 1-year mortality is 2.9%, approximately 3%, which is considered intermediate risk. And also he has 38 or 39% likelihood of severe multi-vessel coronary artery disease. How about his perfusion imaging? So this is the information we learned from the treadmill test, but perfusion imaging also provides us additional data. In this case, just for orientation, the top part would be short axis of the heart. The top row is the stress images. Below that are the rest images. Again, stress images, rest images. The half part of the slide is the short axis view, followed by the vertical long axis view, and the bottom is the horizontal long axis view. And here, if we look, we will see a defect that's involving the septum of the left ventricle and the inferior wall, an inferior septal wall of the left ventricle. And this is reversible. It is apparent on the stress images, and for the most part, it is reversible during rest. This is also can be seen on the vertical long axis and the horizontal long axis of the heart. If we put it all together, the amount of the myocardium involved with ischemia, in this case, reversible perfusion abnormality represents myocardial ischemia, is 13% of the myocardium. In addition, if we look at the cavity of the left ventricle on the short axis images, you will see that the cavity appears to be larger during stress compared to rest. This is a phenomenon called transient ischemic dilation, in short TID, and his TID ratio is 1.2. So in summary, this patient has a reversible perfusion defects involving the anteroseptum and the apex of the left ventricle, also the inferior wall and infraseptal wall of the left ventricle. He's got 13% ischemic myocardium or ischemic perfusion deficit. He's got transient ischemic dilation of 1.2. In this case, normal should be less than 1.19. So the transient ischemic dilation, in summary, it is left ventricular cavity volume appears larger during post-stress images compared to the rest images. Therefore, the ratio would be increased when you have transient ischemic dilation. It represents extensive subendocardial ischemia, giving the appearance of a larger cavity. It is associated with severe and extensive coronary artery disease, and it predicts adverse cardiac outcomes. In addition, in this patient, his ejection fraction during the rest images was 56%. However, post-stress was 47%, 9% drop in left ventricular ejection fraction. This phenomenon implies post-stress ischemic regional wall motion abnormalities due to stunning or severe myocardial ischemia, and it is associated with severe uh, an extensive coronary artery disease as well. So how we integrate the myocardial perfusion imaging with the Douk treadmill score. So myocardial perfusion imaging does provide incremental prognostic value above and beyond the Douk treadmill score. Although Douk treadmill score provides valuable outcome data, and as you see, when you have low Douk treadmill score, your event rate in this particular study is 0.9%, and it increased in a stepwise fashion. It's 2.5% for moderate Douk treadmill score and 7.7 in high Douk treadmill score. However, when we implement myocardial perfusion imaging data, being normal, mildly abnormal, or severely abnormal myocardial perfusion imaging, we will see also a stepwise increase in risk, irrespective of the Douk treadmill score. You see that in low Douk treadmill score, moderate Douk treadmill score, and high Douk treadmill score. Most notably, that in patients who have moderate Douk treadmill score, abnormal myocardial perfusion can really separate risk even further. And you will see that if you have normal perfusion imaging, the annual event rate in this particular study was 0.4%, very similar to patients who have low Douk treadmill score and normal perfusion at 0.3%. However, when perfusion imaging is mildly abnormal or severely abnormal, you'll see significant increase in risk, similar to patients who have high Douk treadmill score. So myocardial perfusion imaging is particularly useful in patients who have intermediate Douk treadmill score, which is the case of our patients here. And that is why perfusion imaging is particularly useful in this patient who has high pretest likelihood of coronary artery disease. Myocardial perfusion imaging can better define risk than treadmill alone. Additionally, myocardial perfusion imaging not only can help you determine the prognosis, but perhaps guide management. In this study, patients who received medical therapy versus patients who received revascularization therapy were propensity matched, and the investigators looked at relationship between ischemic myocardium, or the percent ischemic myocardium, and patients' risk. And we would see that around 10% ischemic myocardium, you'll see these two lines are intersecting. So patients who have low burden of ischemic myocardium, less than 10%, you'll see actually medical therapy is associated with better outcome than revascularization therapy. At high risk patients or high burden of myocardial ischemia, you will see that revascularization therapy is associated with better outcomes. And those two lines intersect around 10%. So in our patients who has 13% ischemic myocardium, these data favor revascularization therapy above medical therapy. Therefore, this patient underwent coronary angiography, which shows total occlusion of the left anterior descending artery with left-to-left collateral filling the distal part of the vessel. Additionally, he has severe lesion in the distal right coronary artery. In short, he has severe two-vessel disease involving the left anterior descending artery and the right coronary artery. Since his left anterior descending artery is completely occluded, coronary artery bypass surgery is favored in this case over percutaneous coronary intervention. So how the management decision is made? We're going to re-summarize this case. So this is a patient, middle-aged patients who have stable typical angina, had high pretest likelihood of coronary disease. Therefore, we perform stress myocardial perfusion imaging for additional risk stratification. He has perfusion abnormalities in multiple coronary distribution. Therefore, we expect that he would have severe and extensive coronary artery disease. He has transient ischemic dilation, again, is associated with severe and extensive coronary disease. He's got post-stress left ventricular ejection fraction decrease on his perfusion imaging. Again, this is associated with severe and extensive coronary artery disease. He's got 13% ischemic myocardial burden, and this predicts better outcome with revascularization therapy rather than medical therapy. He's got totally occluded left anterior descending artery, and in this case, coronary artery bypass surgery is favorable for complete revascularization. He has diabetes mellitus, which also indicate that he would have a better outcome with coronary artery bypass surgery rather than percutaneous coronary intervention. Therefore, he was referred for coronary artery bypass surgery, and he did well afterward. Thank you very much.
Hello, this is Gretchen Diemer. I'm an associate professor of medicine in the Division of Hospital Medicine at Thomas Jefferson University in Philadelphia, Pennsylvania. I'll provide the perspective of a general internist for this case. This is a case commonly encountered in general internal medicine. From his history, we know that the pretest probability of coronary artery disease is high. As Dr. Doukky points out, further testing should be considered for prognostic or management questions, not diagnostic questions. This patient is not yet on optimal medical therapy, so that should really be the first intervention, which would include the ACE inhibitor, a statin, and a beta blocker. Using the appropriate use criteria table for a symptomatic patient with a high pretest probability of coronary artery disease, you can see that multiple options are considered appropriate for this patient. So how do I choose which test to do? Understanding what question you're trying to answer with your testing is important. Determining prognosis and severity of his coronary disease will determine your future interventions. I tend to avoid invasive testing initially if I have another choice that's equally as effective. And as I learned from Dr. Doukky's discussion, it's not the fact that the myocardial perfusion imaging test was, quote, positive, which may be a way that general internists would look at that, but with a moderate reversible defect, with the presence of transient ischemic dilation and the drop in post-stress left ventricular ejection fraction, those are associated with more severe disease and worse outcomes. That's what promoted the next step for more invasive testing with cardiac catheterization. In summary, the cardiac testing in this case was not to prove that the patient had coronary disease, but this case demonstrates how to choose testing for a symptomatic patient with a high pretest probability of coronary disease and how to interpret the results of that test to inform the next steps in management based on the severity of his disease. With that in mind, my question for Dr. Doukky would be, are there, quote, positive myocardial perfusion imaging results that would not have resulted in him going to a catheterization?
Thank you, Dr. Diemer, for a very nice summary. Your comments are spot on, and thank you for the question. Yes, indeed. This patient, as we noted, he has mild to moderate symptoms of angina. If we refer him for stress myocardial perfusion imaging, for example, and we find that he has only 5% ischemic myocardium, or even 8 or 9% ischemic myocardium, and did not have other high-risk features such as multi-vessel territory ischemia, a drop in left ventricular ejection fraction on the post-stress imaging, and transient ischemic dilation, all high-risk features. If he had none of these high-risk features, which is fairly common, you have, let's say, single-vessel myocardial perfusion ischemia, low burden of ischemia, and no other high-risk feature, it will be completely reasonable to defer coronary angiography, start medical therapy, as you indicated, with statin, maybe angina management, beta blockers, and better blood pressure control. And in addition to aspirin, we could monitor the patient. Oftentimes, angina may resolve completely on medical therapy, and the patient does well. And multiple studies would show that in these kind of situations, medical therapy may be appropriate, and the patient may remain asymptomatic for quite a while, and with intensive risk factor modification, progression of coronary disease also might be altered favorably, and we can conceivably avoid invasive angiography and subsequent revascularization therapy.